Hi everyone. My name is Medha, and my research was conducted on the efficacy of phage prophylaxis against nosocomial bacterial infections. And throughout my presentation, I'm essentially just going to walk through my process and the research itself. All right. So naturally, the first thing that I needed to find was a problem. I have aspirations in medicine, so I've been around enough hospitals to know vaguely what surgical procedures look like. So even before the surgery happens, doctors will often give patients antibiotics as a precaution so that they don't develop a bacterial infection at the hospital when their immune systems are so vulnerable. So this is called antibiotic prophylaxis, and it's also provided for patients recovering from a viral infection or a fungal infection or something along those lines as well. And so the issue with this is that a pattern has been discovered. Prophylaxis gives rise to bacteria that are termed multi-drug resistant, which is MDR for short. And nosocomial environments or healthcare settings are oftentimes the most common breeding grounds for these bacteria because of their constant exposure to antibiotics. And so MDR bacteria are extremely complicated to approach, right? Because without antibiotics, we don't really have anything else to combat pathogenic bacteria. And so that's where phages come in. So phages are extremely small viruses which will lyse or infect and break apart bacteria. They were discovered a few years prior to the discovery of penicillin, but of course, once antibiotics became the wonder drug, phage research was just really put on the back burner. And so now, though, phages are being reconsidered as a viable alternative to the now failing antibiotic treatments. And so the efficacy of phage therapy, which is basically the use of phages after the bacteria has been identified, is essentially undisputed. But what if you could eradicate the bacteria before it could even infect you, right? So therefore, I've proposed the use of phages as prophylactic treatment in nosocomial infections. So something that should really be emphasized is that phages are extremely specific in their lysis. A species of phages will only kill a very specific species of bacteria, and that's mostly because of the receptor identification in order to bind and lyse. And so this is actually a huge implication of using phages prophylactically, especially when you're fighting a disease that hasn't even established itself yet and therefore hasn't even been identified. So I chose to focus my efforts on the most common and most aggressive MDR bacteria that are present in the US's nosocomial settings. I'll spare you all the details of what they do exactly, but I've listed them here on the slide. You can see there's Staph A, there's P. aeruginosa, K. pneumoniae, Acinetobacter baumannii, and C. difficile. And so they all range from gram-positive to gram-negative bacteria, from respiratory and gastrointestinal to skin diseases. And so it's really important that my mentor and I focused on a wide variability because of the fact that bacteria are so difficult to treat because there's so many different kinds and they evolve so quickly. So now that we had the problem, we needed to find a way to tackle the implication of specificity. So my mentor and I, we decided to utilize a model that is already in widespread use in phage therapeutics. Essentially, the idea is that phages from different species are given in a cocktail to ensure the eradication of any genetically evolved or slightly mutated strain of a particular bacterial species. However, in this case, we still would need to create a phage cocktail known to kill a broad host range for each of the 5 bacteria. So not only would it be for all 5, but it would also have to be for every single known strain that's resistant to antibiotics. Unfortunately, I can't talk about the exact species of the phages that I wanted to use because phage species are actually trademarked and owned by the companies that discover them. However, the phages that are used are going to be administered via IV, nebulizer, topical powders, or through an oral route. And so the administration really just depends on the site of infection. So in the case of prophylaxis, a phage cocktail can be determined based on the state, if it's in the US or another place that actually has states, or it could just be vaguely just a country. And so it should be administered as it's seen fit. So for example, in patients recovering from primary viral infections pertaining to respiratory or gastrointestinal tracts, the cocktail should be given orally or via nebulizer. And for patients who are recovering from some sort of an invasive procedure or large wound, there's a more likely risk that they're going to contract a pathogen through the skin or through the break in the skin. And so phages would be administered via a powder or some sort of a topical cream. And so now that I've had a lot of background research, I now needed to create an experimental design. So the design that I proposed was to assess the efficacy of phages as prophylactic treatment for nosocomial secondary infections, which is essentially the purpose of this study. And the control for the study will essentially be 50 patients within a healthcare setting who are given the regular prophylactic procedure for that healthcare setting. So it could either be no prophylaxis whatsoever, or it could be some sort of an antimicrobial pretreatment. And so control group 1 would be 25 of these 50 subjects recovering from some sort of a primary viral infection, and then group 2 would be the other 25 who are instead in a post-surgical or deep wound recovery. And the experimental group would be 50 more patients within the exact same healthcare setting who are given a prophylactic phage cocktail. And so experimental group 1 would be 25 of those 50 who are once again recovering from viral infections, and then group 2 would be the 25 that are recovering from surgery or wounds. And so it was really important that we had them in the same healthcare setting, because they all of the, whether it be the experimental or control group, need to be exposed to the same bacteria. And so each of the patients would then be reassessed after a week of being given the first prophylaxis, and the blood tests would be done to identify any existing pathogens, and further tests may be done to determine phage activity in the experimental groups. So since I haven't been able to actually conduct this study, both because of COVID and also because it's a clinical proposal, and so it must be FDA approved before I can do it, I had to look into research that had already been done in phage therapy to identify the projected results of this study. A multitude of results can be expected from this study, and these were actually derived from studies that my mentor has done as well. And so in the case of a successful prophylactic phage cocktail, the blood test should show traces of or absolutely no signs of virulent pathogenic activity in the body. And if this is true, then essentially the subject might fully recover based on a dose-dependent phage therapy after the fact. And the recovery may be quicker if, say, the prophylaxis was administered directly to the colonization of bacteria. And it would be quicker that way, because the phages won't have to go all throughout the body to find their host. But in the case that the phage prophylaxis is not successful, the patient may be infected with a nosocomial bacterial infection. And there's multiple reasons why this may occur. One of them being that the administration of the prophylaxis was given in too small of a dosage than necessary. But there could also be the fact that the patient may contract a bacterial infection that wasn't even considered in the prophylaxis cocktail. And so the more like unlikely but potential situation is that a patient might develop a allergic reaction after the administration of phage prophylaxis. And this may just be because of using phages in conjunction with other treatments. So if there's pain medication or phages are being used in conjunction with antibiotics, there could be an allergic response to it. So essentially, the misuse of antibiotics and antibiotic prophylaxis has led to an overall spike in resistant bacteria. And for patients with compromised immune systems, MDR bacteria could be extremely life-threatening. Phage prophylaxis can be utilized as a treatment in order to eliminate the contraction of a bacterial illness. Phages can be administered in cocktails of different strains to protect the body from commonly known nosocomial infections. But it is necessary to recognize that the proposed study and the research conducted are not entirely comprehensive because much is still unknown about the true efficacy of phage prophylaxis. So while the individual therapeutic treatment may be regarded as beneficial, phage prophylaxis needs to be studied in much greater detail to truly understand its benefits and drawbacks. But ultimately, prophylactic phage therapy might just be an extremely crucial alternative to the now failing antibiotic treatment. Thank you for your time.